Welcome everyone to the second part of the final episode of our Smith & Nephews sponsored special edition podcast series. I am Andrew Duckworth and a warm welcome back to you all from your team here at the Bone and Joint Journal. As you may know, this special edition series is focusing on hip replacement surgery, including what the current issues are, what emerging technologies may help with these issues, and what the future may hold. In this episode, we'll be building on our previous episodes in the series to explore the dynamic shifts happening in total hip arthroplasty, highlighting some of the cutting-edge innovations and how the orthopedic community is adapting all of this to our ever-evolving healthcare systems. We'll further discuss the rise of personalized surgery, the economic implications of these innovations, and improving the success rates of hip replacement, and bringing together our previous episodes on how implant designs are driving precision, hopefully reducing risk, and improving the efficiency of total hip arthroplasty for us and our patients. So for today's podcast, I have the pleasure of being joined by three guest surgeons and a colleague here from the BJJ. Firstly, I'd like to welcome back Dr. George Haidukewych, who is an orthopedic surgeon based at Orlando Health. George, great to have you back with us.
Hello.
Secondly, I would like to also welcome back Professor Ed Davies from the Royal National Orthopedic Hospital in Birmingham. Ed, thanks very much for joining us again.
Thanks for having me.
Thirdly, we have the pleasure of welcoming Dr. Thane Munting, who is an orthopedic surgeon based in Cape Town. Thane, thank you so much for taking the time to join us today.
Pleasure, Andrew. Thanks for having me.
And finally, I'd like to welcome back my editorial board colleague here at the Journal, our hip specialty editor, Professor Dominic Meek. Dominic, great to have you back with us.
Thanks very much. Great to be here.
So, team, I thought we'd sort of kick off, and I'll maybe start with yourself, Ed and George. You know, you've taken part in the series already. And just to summarize and highlight some of the key points we've discussed so far regarding how the role of personalized total hip replacement surgery is evolving and how this is potentially improving outcomes and reducing complications. So maybe, Ed, if I can maybe start with yourself and then I'll come to you, George.
Yeah, thank you very much. So I'm starting to learn now how do we do the perfect hip replacement? And if we're going to do a perfect hip replacement, then we've got a few choices to make. The first thing is, how do we personalize the component orientation for that particular individual? And I think technology certainly helps us with that. We then, of course, need to execute that plan. And so we need the precision of execution with technology. I think we also need to realize that actually implant selection is a huge part of this. And I think particularly over probably the last 5 years, we've learned much more about design of stems, whether we should be cementing, uncemented, and bearing choices. So it's hugely important, which I hope we're going to talk about a little bit later. And then, of course, when we're executing the hip replacement, we've got to be cognizant of the soft tissues and try and do the least damage as possible. So I think we're building all those things together. We discussed before, I think we don't want to get caught up with technology about, I think, the trap of technology helping us plan the perfect position and technology helping us to execute that plan. That there's absolutely no point in being precisely wrong when you're executing a plan. So as we start to move forward in realizing where these technologies fit, I think we've really got to tease out those two aspects. That where do we want to put it? And technology is hugely beneficial on that. We've got planning softwares now that can really personalize component orientation. But then we need a slick system that within the operating room, we can execute that plan and deliver that component orientation.
That's a really nice overview, and I totally agree. I think it's like you say, there's no point in putting it in perfectly inaccurately or perfectly wrongly. So, George, anything you'd add to that?
Yeah, I think Ed hit the high points that you need to define a target. And how do you do that? You know, there are programs that can help you run simulations to determine an impingement-free arc of motion. I think these are very helpful in patients that have the outlier spinopelvic relationships, fused spines, stuck sitting, stuck standing positions where your typical 40-15 will not be adequate. So recognizing which patients need that further workup and that more advanced planning, I think that's a growing body of knowledge. We don't know how many patients need a 3D plan. Are you okay with 2D? That's a growing body of knowledge, but I think the outliers with significant lumbopelvic deformity will benefit from more sophisticated imaging and preoperative impingement analysis. And I agree with that. The tools we use to hit the target, so to speak, won't be giant robotic arms. I think they're going to basically distill down to handheld robotics or simple navigation tools that are basically transparent to your workflow. They'll hand you a robotic reamer instead of a standard reamer. It'll look very similar, but it'll still help you as a robot would help you, but the technology will be in your hands. I think that'll be the way we evolve in the future.
Yeah, that's really, really interesting, George. I totally agree. And I think like you've highlighted some of the previous episodes where we did talk about these patients who are maybe the outliers, the more complex patients, and where this particularly can really come into its own to really help you in those situations. Thane, if I could come to yourself next, just maybe expand on those comments and what your own thoughts are on the current technologies that are helping with personalized surgery.
Yeah, for me, I think the overall purpose of this technology is to make us as orthopedic surgeons better orthopedic surgeons, which will have knock-on benefits in the long term, obviously. I just want to also second what our previous two speakers have said. The planning before has always been very generic, and now we have techniques that we can plan appropriately for our patients, as opposed to just the generic way of doing things. But more to that, it facilitates actually bringing into play what Ed mentioned earlier in terms of implant design. So if you know the exact design parameters of your implant you're using, it also helps you choose the correct implant for your patient. When you start putting the dynamics together between cup orientation vis-a-vis the spinopelvic movement and the positioning of your stem in terms of the anteversion of the femoral neck, for example. And when you can test this all on a computer before you do surgery, looking for impingement range, it adds to the bespoke planning of each case that you do, which then, if effected precisely afterwards with proper surgery, using the robotic or computer-assisted techniques, can only benefit in respect of our outcomes, in my view. It's fairly commonsensical. And I can tell you that for you, after using this for the last 2.5 years, I really don't have outliers on my x-rays post-op. I have no leg length issues. And thus far, touch wood, no instability issues. So it's also taught me a few things. The processes have taught me that I don't need to use lip liners for posterior approach, for example. I don't need fluoroscopy for my direct anterior approaches. So there are numerous benefits this kind of technology can provide, which will allude to, as we'll discuss later, cost benefits, I think, for the most part, over and above the benefits for our patients. There's a last aspect, which I think is very important. We all know that outcomes are really dependent on volume. So large volume centers and surgeons do better. Now, for me, this kind of technology really can benefit the lower volume surgeon, bring down their complication rates and all the benefits associated with that in the long run. Yeah. So ultimately a no-brainer.
That's really interesting. Then I think you've again highlighted some of the points we've discussed already in terms of reducing those outliers in terms of your what you're seeing in your post-operative X-rays, and certainly my colleagues would say the same things in terms of the reproducibility you get with it is quite marked. And I think also, like you say, trying to reduce those complications, and something that's been discussed before is actually hip replacement is a very successful operation. The complications are thankfully rare, but they are, when they do occur, we know they are big and actually are very, very impactful to the patient and the healthcare system. And I think that's something that you're really highlighting nicely there. And sort of, Dominic, that maybe brings me to you in terms of, anything you would first of all add to what we've heard already there. And where are we at sort of with the data for this at the moment? Because it's relatively new in the grand scheme of things.
Sure. So, I think everyone's really covered well this sort of idea of imaging, digital planning, custom implants, advanced surgical technologies, etc. And we're aiming for this safer, faster recovery and natural fit function. But I think from the journal point of view, there's been some interesting articles really on prediction from the spinopelvic point of view. Last year, there was one from Tang et al. And it was really a preliminary validation study, but looking at evaluating patient-specific algorithms from the sagittal pelvic tilt idea. They came up with a nice classification that had good reliability and validity in predicting what the pelvic tilt would be before and after a total hip arthroplasty. And I think that sort of research is where we're going to make the big leap forward. It means that we're able to preoperatively assess from the sagittal alignment like what the functional orientation is, and a lot of these algorithmic programs will then help us understand where we want to put it. Those sort of studies were some of them are retrospective, obviously, by nature. So I think as things get more prospective and the data from a lot of the robotic works that we're doing can be used, then that will be very useful. Yeah. And I think there's a really nice summary we done last year by Fontelis et al., which was really about again, about the spinopelvic movements, which I think really that mechanics is where we really need to understand and where we're going to have to future-proof for the hip replacements. So understanding them, what imaging, what post-operative changes we're going to induce. Things like whether we do the hip or the spine first. In some of these, if some patient's going to get complex spinal surgery, do we do that first before doing the hip? Because that's obviously going to change the whole mechanics. I think algorithms that will help with that will be very useful. As you say, there's implant-specific considerations, head sizes, dual mobility, strategic use of constraint, but it's really the enhanced technology and how we interpret that spinal pelvic. And I think that's where the role of AI will certainly come in. And we're seeing that in a lot of papers being submitted using that big data. And when we know what we want to get from it, we can use AI. But we have to realize that rubbish in, rubbish out. So AI will only be as good as what information we give it. We'll need to have solid validation externally of these algorithms. But I think to conclude, there's really is an increasing understanding of the spinopelvic mechanics, and that's where I see a lot of the future research going.
Yeah, that's great, Dominic. I think a really nice overview, like you say, of some of the studies that have been in the journal, and actually sort of again highlighting one of our previous episodes in the series about the importance of the spinopelvic area, and actually how this may really be a game changer there. And that's sort of, I think that leads us quite nicely. And I'll come back to yourself, Ed. Talking about data and sort of big data is obviously the role of the registry data. And how do you feel this can be used to influence implant choice and determine outcome as the data evolves in this area?
Yeah, I think it's hugely important. I mean, you said earlier, one of our problems in hip replacement, which is a nice problem to have, is that we are so successful. And therefore designing conventional studies, RCT or prospective studies to look at complications or outcomes is incredibly difficult because we're so good with hip replacements. And as you said, the complications are rare. So how do you solve that? Well, you look at big data and you look at large numbers, and that's exactly what the registry does for us. I think there's always some caution with that, and I think certainly over the last few years we've realized that actually when we're looking at joint registries, revision for us now is not the only critical endpoint. We need to accept that periprosthetic fractures are a major operation for patients. And we need to be collecting them, and obviously the registry is starting to do that. But in the legacy data that is regularly quoted and has led to essentially telling us what to do, the foundations of that have really been shaken. So like everything, it's great as long as you're looking at the right things, and particularly over since we've had highly cross-linked polyethylene, really, which was the big game changer. The indications for revision have changed. And now if you choose a good bearing, periprosthetic fracture is probably the most common reason why you're going to need a major reoperation. And if you're just looking at revision, you're excluding all those poor patients who had an ORIF, and you may be making the wrong assumptions. And I think that's particularly worrying when it comes to the sort of legacy information that actually is still used here in the UK to say that if you draw a line at 70 and you say if you're older than 70 you should have a cemented stem, and I think we're really showing that probably wasn't true, and what that was based on, actually we've missed a whole group of patients that needed an ORIF, and also implants have changed to address that. And if you choose a good uncemented stem, then actually you could be getting lower overall reoperation rates than if you did use cement. So I think caution, but I think they're hugely valuable, and I'm really pleased that we're starting to tease out some of those concerns to make it more robust, so that we can trust it more.
Yeah, that's a really nice overview, like you say, of the ridge data and what it can and can't do. And I think we'll come on to that in a bit more detail actually when I speak to Dominic. But maybe before I do that, I come to yourself, George, and then yourself, Thane. From your own perspectives and your respective nations, really. What's your feeling about the use of maybe not registry data, but big data in this way?
Well, we have the AJRR, which is quite huge, and there's imperfections in the data collection as far as even surgical approach isn't often entered. So I'm a little dubious about putting too much weight on the conclusion unless there's a very strong signal from a registry, especially early in the learning curve. For example, as far as this preoperative, more sophisticated impingement modeling, I don't think we're capturing that right now as to what methodology the surgeon used to template or plan the hip that he or she implanted. We don't know that. It would be fascinating to know that. I don't think we're capturing how many levels of spine surgery or whether there was a stiff pelvis stuck in 50 degrees of extension with a 2 centimeter leg length discrepancy. So the complexity of the preoperative hip, I do not believe, correct me if I'm wrong, is captured right now in any registry. It's simply the methodology, the approach, and the outcomes, and the diagnosis, age. That's about it. So I think we're going to need to get much more granular because, as you said, hip replacement is so successful. The number of patients needed to show any meaningful difference is massive. But I do think if we get more granular and define the super high risk patient for instability or component malposition, I think we'll see a signal earlier with some of these new technologies.
That's really interesting, George. And I think you make some really good points, like you say. And I think we'll talk. We've since in this at the journal is the registry data is very useful, but it has its limitations, and you can only tease certain questions out of it. If you push it too far, you'll get maybe get a signal that's not real or no signal at all, like you say. And I think that's a really interesting point. But actually, as not only does the technologies in hip replacement, all technology evolves, our ability to capture that more granular data, I think, is definitely there. Thane, what are your own thoughts on that? Based where you are.
Well, we certainly enjoy the British Joint Registry. It's used as a reference regularly, and as Ed said, extremely important. And I just want to second what both he and George said, in that there are some parameters in the registry which are perhaps necessary. I'll give my thoughts on that process. So in South Africa, we have actually quite a young patient group, and a high percentage of my joint replacements are fairly young. And these are cases which I think need to be looked at in even more detail, given that we want extra longevity out of our joint replacements for this cohort. Now, the other thing about looking specifically at sort of generic patient parameters and then looking at design parameters, the problem we have, of course, is that both the strength and the downfall of the registry is that it gives an overview for all sorts of surgeons. However, I would like to see if we could perhaps divide out those surgeons who perhaps have a bigger love for the business of doing hip replacements, if you want to put it that way. And it might be reflected by a simple tick box as to whether or not robotic or computer-assisted surgery has been used in a case or not, and have that reflect on the registries, so that one can tease out whether or not these systems that we're using actually have benefit in the long run with regards to the big data that we can get out of a registry. And then I want to second what George said. As far as I'm aware, in the orthopedic literature, we still do not have a simple classification system for what is a simple primary versus a difficult primary. And it's in my country, it speaks a lot because we have fee-for-service processes with our medical aid funders. But they give us the same amount of money, whether it's a complex primary, post-fracture, severe DDH, whatever the case may be, versus a simple osteoarthritic hip joint. I think this is actually this is sort of needed. And if anybody's interested, I'd love to collaborate with this. We are sort of working on a simple system, much like the anesthetic ASA grade, but something similar for hips, where you can differentiate between what's a difficult primary and what's not, and then interpret your results accordingly. That sort of thing is needed, I think, for big registries.
Yeah, no, I totally agree with that. And it's really interesting you say about, knowing about, robotic versus not robotic, or how you want to phrase it. And I think actually we do need that information, don't we? Because we need these answers relatively fast, well, as soon as we can, because actually we need to know if these are actually these interventions or innovations, shall we say, are actually having a difference. And that and that's what will link us probably to our next session on the health economics of it. But before we do, Dominic, it's interesting listening to all three of our guests. They highlight a lot of the issues that I certainly, and I know you'd hear at the editorial board when we discuss registry data and the pros and cons of it. How would you sort of sum that all up?
Yeah, no, absolutely. I mean, I think there've been lots of good examples of the pros and cons there. But I mean, things like the population level versus individual level, these are large populations. They're not patient-specific variables being included, like the bone morphology, as we've just talked about, the shape of the femur, previous osteotomies, etc. So something that performs well on average may not be the best choice for that individual. Selection bias, some implants are used in younger, healthier implants. The journal published a few years ago that ceramic has lower infection rates, but they go into younger, fitter patients. So there's always a possibility of association rather than causality. So we have to be in mind that patient selection may be the issue rather than implant superiority. And there's, as we've discussed, heterogeneity in the surgical techniques, various surgeons using various types and high volume, low volume. You may be reflecting learning curves rather than implant designs. Incomplete data. If we don't hit a high 90% entry, how valid is that data? So, it also won't record activity level, often function. We've had difficulty getting our PROMs into our NJR data. So we just really are tend to look at revision-free survival, which is a very crude outcome, really. We don't know about pain relief, gait restoration, return to sport and work, etc. There's also a lag in reporting. These registries take a while. And it may well be an argument more for implant retrieval and analysis, because otherwise we may not pick up that we're putting in a bad implant for many years and several 100,000 can go in. And again, I think there is a danger of taking registered data from one country and translating it to another. There's lots of things that some are cementers, some cementless, different antibiotic profiles. So I don't think you can take the Swedish or Australian registry and necessarily apply all that to the UK population base. But in summary, it's really valuable benchmark. It guides where you should be doing the research. And I think it's useful from that point of view.
Yeah, no, absolutely. A really nice summary of that of actually the overview of the registry data, certainly here in the UK. I totally agree. But I think, like you say, those finer things, you're talking about PROMs, and actually, Thane was talking about he has a younger patient population with these, and as you all do now, how are they doing? What are their main key outcomes? You highlight that very nicely. So, yeah, so I think that sort of brings us on nicely to my sort of final question, which I would appreciate comments from you all, because ultimately the outcomes for the patient are obviously very, very important. But in a lot of the systems we work in, certainly ours, money is tight, and so the health economics of all of our innovations and interventions is very much scrutinized, and so. Of the innovations, the innovation we've discussed here today and throughout this series, what are your individual thoughts on our ability to show that they can drive cost savings in the healthcare systems? I think improving outcomes, I think probably might be a little bit easier, but maybe not. But in terms of what are your thoughts on how we're going to do that, and if you think it is going to be possible? Ed, maybe I'll start with yourself.
Yeah, I think the first thing to say, it's very difficult. Going back to what we said earlier, because hip replacements are so successful, so we're chasing after a very small amount. However, as we know, in arthroplasty, if you get an infected arthroplasty, that costs a fortune. Or if you need a revision, if you've got if you've got multiple instabilities and you've needed multiple revisions for instability, that's hugely expensive. Not to mention the effect on the individual. So I think these things are difficult. When it comes to implants, I think that's probably slightly easier to look at cost of implants because of the revision rate and periprosthetic fracture. I've got an anxiety with technology, though, is how quickly we make our mind up about technology and that we don't stifle innovation. And the way the world is moving, we're moving towards technology, and I think one of the big things about technology is reproducibility. And I suppose I've got a concern that we're going to struggle to show the economic benefits of technology in the early phases because of what we mentioned earlier, that we're working out that interplay between where we want to go and the execution. I suppose I'll throw in that I think possibly the revision area with technology may be vastly more cost effective than the primaries, but I think we need to be a bit more savvy, which is we need to, as I think George says, we need to work out who's the ones that are at risk and maybe invest more money in those at-risk patients. And that would be hugely beneficial to the whole health economic plan. But let's be cautious as we're developing technologies and learning that we don't throw things out too early and then regret that in years to come.
I think that's a really good point, Ed. And like you say, it's interesting your point as well about the revision surgery and whether that is actually an area where you can show benefit and then it will just develop with time. George, what are your thoughts, and particularly from your own practice and in the States?
Yeah, obviously minimizing complications is your biggest bang for the buck. But that aside, because that'll take a long time to prove that, right? But short term, there is a very easy to prove benefit of this technology is you're faster in the operating room. You can get more cases done per day, get more patients taken care of, because you have a 56 cup and a size 5 high offset stem with a 36-0 ball. Your neck cut, that's impingement free. You don't have to trial 5 or 6 times. So you are more efficient in the OR, and more importantly, you have to bring less cases to open between cases. You may only open 2 or 3 pans instead of 6 or 7. You don't need all the trials. You don't need all the implants. So that saves a lot of time in a surgical suite, and also saves a lot of autoclaving costs. In the US, we still autoclave and wrap all our trays. I know it's a little different in the UK, but all of that time and personnel costs associated with turning instruments over is a significant cost that's very measurable right now. And the other one is fluoroscopy time. If I'm a DA surgeon, I use probably 30%, maybe 20% as much fluoro as I used to. That's quicker, that's better for the patient, it's cheaper. So there's definitely a short-term benefit that's easily measurable. The long-term benefit will probably take a decade to prove, given how successful total hip arthroplasty is.
That's a great point, Serge. And like you say, I think you talk about, in terms of efficiency, I think that's a big problem in lots of places, and actually trying to improve that, like you say. And actually, if you can get even just one more case in that day, that has huge implications, doesn't it, over time? And also, like you say, in terms of sustainability, you're not opening multiple impacts and everything like that. And we've talked about that in our previous episodes about how it can be such a tangible benefit. And that's a really interesting point about how we will see that quicker. Thane, what are your thoughts on that?
Yeah, I've got a few things to highlight, I think. So robotic assisted surgery is expensive from a capital outlay for continued maintenance, and then there's the usables, and this is what many systems bulk at. If you think about the UK and NHS buying in a robot, they just don't want to put that kind of money down without definite evidence. So it intrigues me that some papers actually looked at the difference, looked specifically at computer-assisted models, which will give us the precision, arguably, that we get out of a robotic system, a huge, bulky robotic system, but bang for buck in the sense that there's far less cost outlay as far as those cases are concerned, with as much benefit. And then the one which everyone's forgetting, of course, is the preoperative planning, which we all like and talk about all the time in terms of doing the right planning before the time, which doesn't really cost that much. It's essentially software. So big benefit is to my mind, it's sort of a no-brainer. And there's some good papers from the States which have actually shown that the cost per event with large volume centers is cheaper for the computer-assisted and in some cases the robotic-assisted procedures that are done. But there's one aspect which everyone doesn't really look at maybe seriously, and that's litigation costs. So, if you think about the simple aspect of leg length discrepancy, it's a big draw card for lawyers. And to get that simple parameter correct every time is just going to take that kind of cost out of the economic system completely out of the equation. So that's something that not many of us think about necessarily. It might also drive down our our insurance costs. So there are other aspects to this which need to be kept in mind.
That's really interesting thing. Actually, those latter points, like you say, people don't really consider that, but actually huge implications for the healthcare system and society as a whole, in terms of costs. Dominic, just final thoughts on that, and in terms of, it's going to be
Sure. I think really actually we can learn a bit from our knee colleagues. Looking through the literature, there was a randomized trial on cost effectiveness of surgical reconstruction for the ACL versus conservative management, and that actually showed reconstruction as a management was effective. It was more expensive, but 18 months the better function meant that the patient was less using up resources, so it was cost effective. And interestingly, you mentioned about the revision scenario. There is articles showing the cost effective of dual mobility in revision, and that because it reduces dislocation. That was a couple of years ago in the Bone and Joint Journal. Of note, it was actually recommended for the younger patients, which is counterintuitive, but the older patients don't live as long and therefore they maybe don't get the cost effective balance. So there's lots of interesting subgroup analysis you can do with that. But again, going back to our knee surgeons, just this year, my colleagues in Glasgow published in the robotic assisted medial compartment uni knee. Now that actually took 10 years to show the cost effectiveness because they showed that they had no revisions at the 10-year results compared to an 87% survival at 10 years. So I agree, we are going to have to wait a long time to say maybe show some of these cost effectiveness, but it doesn't mean that technology isn't going to be useful. And even if having to put money out front, if you're getting a longer survival of that implant, it will pay in the longer term.
Yeah, no, I agree, Dominic, and I think that's a really nice point to finish on in terms of actually we may have to invest a bit, but in the longer term, and actually as George has highlighted, maybe in the shorter term, there's actually some notable financial benefits that can be seen. Well, I'm afraid that's all we have time for, but thank you to you all for taking the time to join us and for a great insights and discussion, and really bringing together a lot of the topics that we've covered in this series. It was really great to have you all with us. And to our listeners, we hope you've enjoyed our special edition podcast today. And a big thank you to Smith & Nephew for sponsoring this series. Feel free to be in touch with us about anything we've discussed here today. Thanks again for joining us and take care, everyone.
Thank you, Andrew. Thank you.
Thank
Bye.
you.